right, good morning, everyone. Welcome to Pediatric Grand Rounds. Thank you for joining us online and in person. Today's speaker is Dr. Camron Johnson. Dr. Johnson completed her medical training at Philadelphia College of Osteopathic Medicine and her residency at Geisinger Medical Center in Pennsylvania. She served as chief resident of pediatric hospice. She transitioned to general pediatric care over 20 years ago and came to Southwest Virginia. She currently practices breastfeeding medicine at 3 Peaks, Pediatrics, and Lactation, caring for infants and mothers. She serves on the board of the Virginia chapter of the AAP as breastfeeding co-champion. She's also assistant professor at VTC SOM. Please give a warm welcome to Dr. Camron Johnson.
Good morning, good morning. So I would like interaction during our conversation. So please feel free if you have questions or concerns that you want to go through, stop me and we'll talk about it then. I am going to talk to you a little bit about an issue that kind of showed up in the newborn nursery after identifying issues in the clinics. So today what we'll do is we're going to talk about these kids that look like they are perfect and ready to go, but they are just not quite ready to be prime time yet. So these are the infants that we're talking about that are in the newborn nursery, not in the NICU. The newborn nursery is somewhere between about 34 and 38 weeks, and being able to support them on their journey. So, try again. Adapt. Okay, so specifically what we're going to talk a little bit about today is looking at the feeding obstacles that newborns, specifically preterm newborns, face. We're going to talk about the Stanford Protocol that was from the University of Stanford in California and our implementation of that here in the newborn nursery, as well as look at the milk composition for both human milk, preterm and term breast milk, cow's milk formula, and also the donor milk that has been pasteurized, and we'll go through a little bit about that. We're also going to talk a little bit about what the Virginia chapter of the AAP is doing for its advocacy efforts specifically related to supplementation of donor milk. Okay, I don't have any financial disclosures. So I'm going to start with a case because that's how this came up in the community. So Leah is a 3-day-old female born to a 38-year-old G1P1 at 36 and 2/7 weeks gestation. Mom had uncomplicated pregnancy until she developed preeclampsia at 35 weeks and was induced because of pressures that were not easy to control. She did get magnesium during the labor process. And then labs for mom, nothing was significant on her prenatal labs with the exception of mom's blood type is O positive, infant was A positive, but Coombs positive, and the infant growth parameters at delivery were appropriate for gestational age. Mom shows up on day 3 following delivery, and she says, this baby is so good. She sleeps all through the night. Mom's not sure if her milk is in yet, but she thinks that she is latching well and has no pain with that process. On physical exam, this infant was 18% down from birth weight. And baby's pretty sleepy and she's jaundiced down to her belly. Can I ask how many residents I have here? Oh, good. So I'm going to ask you lots of questions. What are the red flags?
18% below the birth weight.
18% down, right? Where do we want to see them down? Across 10, right? And there's some evidence that we need to be supplementing earlier and not letting these preterm babies fall lower than about 8%, especially because of their risks. Yeah.
Coombs positive.
Coombs positive, right? Puts them at risk, right? So 2 parts to that, right? One is the risk for the hyperbilirubinemia, right? And then coincide with that 18% down, what does that do? That dehydration compounds that, right? What else?
Sleeping all through the night. Kiddo should be waking up every 3 hours.
Yeah.
Hungry.
If not more, right? So the every 2 to 3 hours is generally what we say for the term infant that is nursing, and that has to do with kind of the rapidity of the metabolism and how quickly that goes by. But you're absolutely right. So if we are feeding every 3 hours for a newborn, that's about 8 feeds a day. And we want newborns to be doing more often, especially as we are kind of trying to recover from that. Now, mom got magnesium, which means she got IV fluids, right? So what does that do to our birth weight? Yeah, so potentially, we don't have any idea on day 3 how much fluid this mom got. It's feasible that the baby's birth weight is a little bit inflated. No way to measure that. But there are some studies that have looked at if we have infants that have this huge loss, we're comparing discharge weight versus rate. So, but what we have today is babies 18% down. Anything else that you see that you were worried about? Premature, right? Yep. So that does a couple things. So we know that there are a couple things, obviously this spin is going to be how do we support moms in this breastfeeding space for preterm babies. We will talk a little bit about supplementation from different formats, but the goal is to support babies and infants with getting them the best nutrition that we can, right? So risks for moms not being able to produce enough breast milk coincide with maternal issues, right? Whether it's chronic health issues, insults related to pregnancy and delivery, if baby has underlying health issues that we are struggling with, if there's more supplementation in 24 hours, what that does is it decreases the amount of time that the breast is stimulated to bring down or to stimulate the milk supply. If there's any breast surgery or any kind of even traumas to the breast, including piercings or lobectomies, not lobectomies, but like an abscess or something, any kind of surgical intervention to that breast that would potentially disrupt the duct flow. So we are specifically going to be looking at infants less than 38 weeks or underweight. There we go, that works. Okay, so when we look at the preterm infant, there are a couple things related to that, and you guys have alluded to several of them already. Number one, mom can have a delay of the milk production, and there's a couple of reasons to that, which we've alluded to, one of which is just stress, right? So whether that's emotional stress because of the worry, whether that is physical stress because of the pregnancy, whether that is hypertension in the pregnancy that's caused issues at the placental level. There's lots of things that go into that. The infant immaturity, we'll go through a little bit of this, but what we see is those infants are really sleepy, right? They're hard to wake up. And the other part of that is the oral mechanics that go into actually being able to attach and transfer the milk. Because of those oral mechanics, they don't transfer milk out of the breast well. So even if they're getting something and they're latching well, they have a harder time doing that. And we have a hard time reading their feeding. When they're sleepy, they also don't cue to feed like they should, right? They're such a good baby, they sleep through the night. All right, so when we look at the feeding mechanics, this is for all comers, specifically for preterm infants. There's 3 phases that we want to kind of look at, and you'll see the different symptoms when they come to your office and say, my baby's gagging all the time, right? They're dribbling out of the bottle or the breast. And that gives you a clue of where that deficit is. So is it in the mouth? Is it in the oral phase, right? The second place would be in the pharynx. So those kids especially struggle with a faster flow or managing a bolus, even if it's not a big fast flow, it's just a bigger volume, and they have a harder time managing that. Those are the kids that end up with apnea bradycardia in our NICUs, right? They just can't manage that. And the other part is the esophageal phase, and we've all seen that with reflux. Reflux is hard to manage in the little ones because there's not a lot to do other than keep them elevated, the smaller, more frequent feedings. For a preterm infant, they need more, and so it's this constant battle, right? Okay, let's talk a little about the Stanford Protocol and what that means. Because what we need to be doing is looking at this infant from the perspective of how do we support them until they reach their term space? because that's where we typically will see the sleepiness improves, their oral mechanics improve, they're alert enough to be able to transfer that milk, they have a good suction pattern in the oral phase of their feeding. So the Stanford Protocol is specifically geared for children under 38 weeks. There are different parameters for supplementation depending on what their birth weight is. So we'll go through that in a second. But the basic premise is 8 to 12 times a day, they're direct feeding. This is primarily because we want the baby and the mom to be able to recognize that interface, right? So the mom knowing how to latch the baby, as well as getting a good position and transfer potential from that, and the baby learning that that's where they're potentially going to get their milk. That's important. I know you guys have seen the infants that mom wants to breastfeed and all they have ever had is a bottle and they don't know how to latch, right? So that's where people talk about the bottle confusion or nipple confusion. You'll hear that in different ways. So we want to really help stimulate that. The 24-hour rooming in and skin to skin are part of the protocol here in our newborn nursery and pretty standard of care. But here's where this is going to be different from our newborns that are term. So we want to teach them to do some hand expression early on. And hand expression is important for a couple reasons. Number one, in that in that first few hours, we're getting such small amounts of milk that colostrum is drops. And if you have it into a pump, or whether it's electric or the hands-free or the manual pump, it gets lost in the product, not into the baby's mouth. So a lot of people will teach hand expression into a spoon that you then immediately will provide to the infant, or you can hand express into a cup and then suck it up with a syringe and give that. Anybody see that in the newborn nursery? Yeah, right? Pretty standard. But that hand expression becomes super important. There's really good data that comes from the NICU where moms that are exclusively pumping, the baby cannot go to the breast. That baby, if we want to support that baby getting mother's own milk. And so if mom is hand expressing while she's using a double electric pump, the output is 40% more. So it has real benefit to be able to do hands-on, and it's off-word. So if we have someone to support them through that process right from the very beginning, it goes a long way. And initiate pumping by 24 hours of age. Really, that's to help them understand this is a long-term process. Our goal is not to fix this within the hospital stay. And that's the message we should be saying as well in our offices. This is the supplementation, okay? So the supplementation is based again on gestational age and weight. And what we're doing is giving incremental greater volumes depending on the age of the child. So between birth and 24 hours, they get a smaller amount, 24 to 48, they get a little bit more, and then after that, we are giving more, especially when we are under 6 pounds. And here's your 8% mark. So if that baby reaches a weight loss of 8%, we just start giving, right? And we'll deal with the consequences of the dribbling and with our maneuvers to be able to support those oral mechanics. So this is the protocol that we've put in place. And there's a lot of resistance to this. Anybody been in the newborn nursery and had a mom say, I don't want to give my baby a supplement? Yeah, all the time, which is great. I mean, from my perspective, I'm so excited that moms are recognizing this is the best for my baby. I don't want to give them anything else but my milk. But we also need, it's our responsibility in the hospital as well as in the clinics to be able to say to them, we're going to support you in the long term, right? Let's meet our ultimate goal, not necessarily today, but 2 weeks from now, 3 weeks from now, 6 months from now. So what it looks like in the newborn nursery. We're going to we're going to first direct feed, working on getting a good latch, good positioning, so that mom has the skills to be able to continue that down the line. and then supplementing with a spoon initially in the first 24 hours. It's a weird skill, but they do great with it. And when I've had babies that are struggling to get off of a bottle, like the plastic feel, we will switch to either a spoon to supplement or there's a feeding cup that you can use that's silicone. And my favorite one is a shot glass. I've only had one parent tell me they don't have a shot glass. And the reason is it's small volumes. It's usually an ounce worth. And you can just put it to their lip and they'll lick at it like a kitten. And that's what you do here. So the only thing that baby recognizes as a true suck is at the breast. Okay, so the first part is newborn nursery. Now, how do we proceed forward with supporting milk as mom is going home? And what that looks like is a couple different things. First off, we want to make sure mom knows how to do a deep latch. We want to make sure that the baby is face on to the breast. I tell everybody we want an air traffic controller, right? Arms around the breast, face on, chin up. You try and eat like this. You try and swallow with your mechanics, with your head turned to the side. It's not easy to do. So we want to set that baby up for that good positioning. It also feels better for moms when they have that face on, chin up position. Now, I found this, I thought it was so cool. Let's hope it works. Megan worked her magic. Hey! Okay, so here you can actually see this infant is suckling. I want you to first look at positioning. Nose right up against the breast. Chin in the breast. Baby is face on, which means ear, shoulder, and hip are in a straight line. Now I want you to look a little bit closer and see if you can find...
Use the mouse.
Use the mouse. Okay, thank you. So this is the actual end of the areola, right? So it's not moving in the mouth. It is way far back in there, and the idea is that the hard palate is on the breast tissue, not the nipple itself. And then as they swallow, they'll get a small bolus. What's nice about this is that they can control how much they're getting. If they need a break, they can. They just stop, right? Questions about that? Is where I'm going?
Yeah.
Okay, good. Okay. So our lactation consultants here in the hospital do such a great job. There's not enough of them to be able to hit everybody, to be able to help them in all of these positions at every feeding, but they do such a good job in trying to help moms troubleshoot when there's an issue, and they truly are a partner. If you're there and you see something that you're worried about, ask them. They'll be happy to go and support the moms, and they know all of this stuff. Okay, so what this looks like in options to supplementation and getting moms on milk. Number one is hand expression, top left. So that looks like you actually don't even touch the areola at all when you're hand expressing. And the idea is that you are kind of stimulating the back of the lobules in the breast and then hand pulling that milk to come down. I had a friend one time, we were actually, ironically, at an AAP conference, and she forgot her pump. And so she pumped 5 ounces using hand expression. It's possible to do. It's just strange, right? And getting over that is one of the hardest parts of it. The next one is the hand pump. This one's very easy to use in the hospital. I have lots of parents who like this because they can control the suction itself. And in the very beginning, you're not going to get very much. And so all the plastic ends up being in the way of giving those crucial drops. The haka is the bottom left. To me, it looks like a hand grenade. And you squeeze it, put it on the breast, and it's a passive flow. It doesn't actually pull at a rhythmic rate. So it doesn't work in the beginning when mom's milk is not in. And it also doesn't work well if you're not giving some stimulation in some other way because it's passive. So the baby is pulling on the other side. That stimulates all kinds of hormones in the brain that we're not going to go through today that actually releases the oxytocin and it'll capture on the opposite side. this is not a great way to go for an infant that is working and struggling to be able to get enough volume, because we don't want to steal from that one side. The beginning latch gives them the most milk with the least amount of effort. And so if we're alternating and feeding on both sides, being able to put the baby to both sides first and then use the haka afterwards is helpful. And lastly, a double electric pump is by far and away the gold standard. That seems to do the best as long as it's got a good fit. Everybody seen these things? Okay, so why is this crucial in the beginning? And this goes down to the endocrinology of lactogenesis. So in short, all the hormone changes in the breast, in the breast occur during pregnancy, right? So lots happen during puberty, and then during the pregnancy, you start to see a ton of proliferation. So then you get branching within the breasts and differentiation of the ducts themselves. So the potential ability to create milk really happens during pregnancy. Progesterone inhibits prolactin, and prolactin is the hormone that makes the milk. But toward the end of the third trimester, prolactin supersedes the inhibitory effect of progesterone, and you'll start to see moms leaking that colostrum. Anybody seen that? Yeah. So it varies from person to person. It's usually after about 35 weeks, but I've seen it sooner, especially in moms who've already had an infant. And some of them are really smart and they catch it, they save it, right? Which is fantastic. But you can, for these babies that are born early, they may not see any of that. And the hormone levels may play a role. Some of that contributes to that delayed onset of the milk. At birth, progesterone and estrogen levels drop significantly, and then that inhibitory effect of progesterone is decreased. And then at about the 3-day mark, you'll start to see milk coming in, right? It varies a little bit. First-time moms, it's day 3 to 5, where they will start to see a significant amount of milk production. And like we talked about before, it can be delayed. Then you have a period where the hormone levels are significantly higher, but you have to pull it. You don't use it, you lose it, okay? And that first 2 weeks is imperative to be able to stimulate that supply. It's very hard once we get past that 2-week supply, and if we haven't had any good pulling, it's really hard to build a good supply. And it's at a much slower rate is what we typically will do. Usually after they hit that 2 to 3 week mark, we can increase supply over time, but it's usually only like 1 ounce a week if everything is unicorns and rainbows. In that first 2 weeks, we can really drive that supply quickly. So for these preterm infants, they're potentially not going to be able to transfer and stimulate that milk supply in those first couple weeks well, so we have to give them an alternative so that we can maintain that supply. That autocrine control is what drives the 6-month-old lactating parent and the 12-month-old lactating parent. Their supply matches demand. The baby's not pulling it, it goes away. And that looks different when we actually look at the milk. We'll go through the components shortly. But you can see the significant change in what the milk looks like, as well as the volumes that you're getting. So removal is going to be the important part. So for those moms who say, I only want to give my baby breast milk and I only want to have them at the breast, I think that's lovely, but we're at risk to fail. So our language is important. Our language is going to be how we can make that difference for them, both in the short term and in the long term. Questions? All right, we're going to talk a little bit about the milk components, and specifically for preterm infants and why mother's own milk is so important. This is the general concept of what's in breast milk. There's a ton of stuff there. There's proteins and fats, there's amino acids, there's different types of white blood cells, there's the carbohydrate, which is the lactose, and the oligosaccharides. Oligosaccharides have a really important role, and it's added to the different formulas. You've seen the HMOs, right? but it's not the same thing as what is in the human milk. The antibodies that are passed through, the stem cells, there's so much there. Bacteria from mom's gut. And when we look at kind of how this intersects, you can see that what it looks like in the colostrum as well as what in mature milk changes. So by far and away, fat is the most important component for calories in breast milk, but the carbohydrates are much more significant in the beginning. The antibodies are so significant in that first couple of days, right? So the golden milk that we talk about, and there are lots of people who, for whatever reason, aren't able to or don't plan to nurse, and they will still choose to give just the colostrum just for that little bit and then transition for whatever reason. So we, as from a perspective of public health, being able to give the, is this one? No. Being able to give the immune protection with the cells, as well as the different cytokines and interleukins, the growth factors that we'll see, the macronutrients and the micronutrients are wonderful. And actually, it's part of the reason why infants that are breastfed grow differently than infants that get formula. That's the difference between the CDC and the World Health Organization curves, right? So we use the World Health Organization curves because they have more a wider variety of feeding and versus the CDC curves were originally made with just formula-fed infants. So the curves are different, they grow differently. And then all of the supporting factors that go into the breast milk that changes over time. Questions on this? When we actually look at the preterm milk, it looks really different, and it's partly the reason why the NICU goes above and beyond to be able to support moms. They have a designated space to be able to, and a designated lactation consultant just to support them, because their outcomes are hugely different being able to give mother's own milk. So the protein levels are different, the amino acids are different, the growth factors are higher than in term milk. And you can see specifically here, this is the very preterm, this is from 2013. So very preterm, and then the term milk and the preterm milk in comparison. There's a lot of things there to be able to provide them a good foundation. And this is why the goal is to always give mother's own milk primarily, right? Okay, so we talked a little bit about the fat content, the energy content, but I really want to talk about lactose, because you'll hear people talk about, parents talk about infants being not tolerating the lactose that's in whatever from a very early age. They'll say it must be the milk, it must be the lactose. Lactose is a sugar, right? And it is made in breast milk as well as in cow's milk, and it's a pretty good energy source. It accounts for almost 40% of the calories that newborns are going to get. The human milk oligosaccharides is a huge component, and it plays such an important role in their immune protection down the line. So it serves first as a prebiotic for all those good bacteria that are being colonized. And those good bacteria are being colonized from skin to skin at the breast. They're being colonized because of it's called an intramammary pathway, where the lymphatic tissue pulls the good bacteria from mom's gut and transfers it into the breast itself. And so that gets transferred and colonized that infant's gut. And the human milk oligosaccharides actually has a really important role in immune support. So it has a little bit of a bactericidal property, as well as an inhibitory effect for certain pathogens. Moms know about the benefits of breast milk long term. We all do, right? We know that it is the gold standard. What we need to be focusing on is how do we support that gold standard, both in our hospitals as well as the community clinics and down the line. This is my nephew who is exclusively breastfed, left the United States at 2 weeks of age as they moved to Germany. And it's interesting to see the different processes in breastfeeding support in Germany, and in the US it was eye-opening. Both ways, much more support for moms and babies, but my sister ended up getting a mastitis and was admitted for 7 days to the hospital. Okay, these are accepted norms. This comes from Lancet. Lancet did a symposium on breastfeeding in both 2016 and again in 2023. These are a conglomeration of the studies that are done worldwide and looking at different ways to measure it, or looking at the different benefits. It's impossible to be able to measure specifically for most things related to this because the structure of the studies are so different, right? So in general, the increased IQ is like 4 points. It's not a huge difference, right? But they tend to have less eczema and less ear infections, right? They have less malocclusions. That's probably just anatomy. So the space in the breast is much different in the mouth than a bottle nipple, which tends to be a little bit more narrow and shorter. It does not go back to the back of that posterior palate. That they have less asthma as well as less of the lower respiratory tract infections. The constipation is less, specifically because of some of the oligosaccharides and the cathartic effect that goes along with the foremilk versus the hind milk. That's the difference between in the milk itself as they are feeding. There's actually evidence of IgA in the lungs of breastfed babies. And we think that is because they are having a little bit of some microaspirations, and that IgA is probably protective down the line if there's a role in less asthma. Lots of research to be done on this. Not a whole lot of money for breastfeeding support research for this. We can quantify a few things for infants that are provided breast milk instead of formulas. When we compare 50% reduction in pneumonias. Hospital admissions are down, NEC 58% down compared to infants or neonates offered the cow's milk-based formula. DID's difference and long-term malignancy, obesity, and type 1 diabetes is less with that exposure. There's a bunch of things that go into that, partly the immune protection and also some of the gut modulation. This data changed how we are feeding infants in the NICU. So we would use, well, I'm ancient, and so I remember when we switched from formula to donor milk, right? Dr. Herman said, yep, and what a difference it made. So in residency, we would see NEC every single day. There was a child who was new onset, and we don't see that to the numbers that we do now, and that's directly because of the breast milk, mother's own milk versus donor human milk that we use early on in initiations. And like we talked about, mother's own milk is still going to be better than a donor milk, and we'll go through some of those differences shortly. The one other thing that really plays a role in some of these long-term efforts is the microbiome colonization. So much research going on right now and related to the microbiome. NIH has a multi-decade study ongoing currently, multi-phases, looking at all kinds of things related to child health as well as adult chronic disease. And so when we look specifically at the gut, babies that are given human milk, they have a greater diversity of different bacteria in there and larger volumes. There's just more bacteria growing, and that probably is a combination of the human milk oligosaccharides that are supporting that growth. And they also tend to be primarily lactobacillus and bifidobacter, as opposed to formula-fed infants, which it supports a different space. So they have less colonies, less diversity, and they tend to be a little bit more of the pathogenic bacteria. We know very clearly that infants that are, or there are very strict criteria, I'm saying that wrong, there are very clear determinants of the colonization in the gut, and one of which is, are they early? How are they born? Is it a vaginal delivery? Do they get vaginal and stool exposure? Do they get skin exposure and hospital exposures from going through a C-section? Do they have any antibiotics when mom is pregnant versus immediately afterwards? Part of that goes into why we use the Kaiser sepsis calculator now for all of our infants. I mean, again, I'm ancient. When we would have infants on 48 hours of antibiotics pretty routinely, and we were interfering with that gut colonization, right? And then again, what we have fed the baby and what mom eats too, because what mom eats interacts and supports different bacteria in her gut too. So the bacteria that gets colonized changes depending on where they are in their life cycle. So we talked a little bit about the delivery process, the lactation stage. So infants that are just getting milk versus if they're introducing complementary foods, and even as the late lactation. So infants that are, they're not infants anymore, but the 18-month who is still nursing 1 or 2 times a day, that milk looks different. And so you'll see different colonization. And it also varies based on where you're at. So this is comparing China to the US, but the bacteria, I would argue, is different in, say, Southwest Arizona than it is in Maine. And that is meant to be targeted. We see that in some of the data that was presented from the Lancet. So the exposure risk for infants that are born in Bangladesh versus born in London looks different, right? This is some data that's looking at what long-term complications of a dysbiosis looks like. And it is shaping up to be pretty diverse, including every system that we have out there. And we have the benefit and the opportunity to be able to make a huge impact long-term in our health system as well as for individuals. The NIH study specifically is looking for autism rates as it relates to that microbiome, which would be fascinating to see, right? I'm really interested in that one. How the immune protection works is so multifactorial. So the idea here is the baby gets the bacteria at the breast through that intermammary pathway like we talked about, and then the support with the different immunoglobulins, the lactoferrin, which we have not talked about in great detail, and the different enzymes that are there, the cytokines, the lysozymes, as well as amylase all play a role in the gut. Let's talk a little bit about lactoferrin because I want to point that out. That plays a role in some of the things that you'll do when you're evaluating gastroenteritis. Tell me what you know about lactoferrin. What's it do? Why do we test for it?
Sign of gut inflammation.
It's a sign of inflammation, right? So why is it in the breast milk? So moms actually produce lactoferrin. It's a protein, and the lactoferrin has a really important role in the gut of a newborn. It actually wraps around and binds iron. So when you hear people talk about, well, the iron level is higher in formula than it is in breast milk, well, that's true, but it's free iron. Lactoferrin is actually bound, and then it presents to the non-pathogenic bacteria, and the pathogenic bacteria are not able to produce or reproduce because they don't have access to that iron. So it's a pretty significant pathway that really makes a big difference. It also has other immune modulating factors and properties in the gut, but the lactoferrin, you want to make sure you're not ordering that on a child with diarrhea that is nursing because you're going to get sky high levels when it's just a product of their food.
Why it has FER in it, lactoferrin.
Yeah, good point, for sure. The supported elements within the bloodstream with the lymphocytes, as well as the different antigens that are being presented, because the gut permeability changes depending on prematurity. I'm almost done, guys. Mom, like we said, moms know this. 85% of women are attempting to nurse. Now, I will tell you, here we are. This comes from the CDC's report card from the Healthy People Initiative. You know what Healthy People Initiative is? Healthy People 2020, 2025, 2030 is where we're at. So most women are attempting to nurse and provide their baby this good nutrition. And what we're seeing is down the line, we're not able to keep up. Our levels are less than other industrialized nations around the world, period. Specifically, the goal for the 2030 is to see the 12-month nursing or human milk use would be significantly higher, 54%. We're only at 40 right now. And exclusively nursing through 6 months at up to 42%. So the World Health Organization and UNICEF and most other industrialized countries have always had the recommendation that infants are exclusively given human milk until 6 months of age, and then continued nursing through 2 years of age because of all of the changes in the breast that are kind of designed for that child, that exposure, that area. 2024, the AAP came out and actually is now matches that, because it used to say just until a year, and now it's the same. 6 months of exclusive breastfeeding and then continued nursing through 2 years. Our infrastructure is not great to do that. And some of that has to do with societal changes. Some of it has to do with employment changes. Some of it has to do with just knowledge and being able to support this down the line. Now, the Healthy People Initiative, this comes from a immunization survey that's done at 18 months of age. So this is data that families are kind of looking back on. Although if you ever talk to a mom, she probably can tell you the day and the hour that she nursed last. It's pretty important for them to be able to do this, whether they were able to or not able to reach their goals. They can tell you exactly when it was. Right?
Good question online. Dr. Carter said, how do you rectify exclusive breastfeeding through 6 months with early introduction of allergens?
Oh, that's a great question, Dr. Kreider. Thank you for bringing that up. I do that all the time. So recommendation for early introduction of allergens. So if a child, if their family has a significant history of eggs or peanuts in there, essentially what we do is we just wipe the inside of the mouth. So it's an exposure, but you're not going to give a kid an egg. And you're not going to give them peanut butter, but we still want them to have the exposure. And while they are kind of learning self, not self, and priming that immune system, I think it's still important to be able to do. But they just need the exposure. They don't have to truly be eating, and we don't have to put it in applesauce to be able to get that exposure. I also don't do a lot of the like baby food products, so I don't use the processed peanut stuff. I will usually just say, get a little bit on your finger and wipe it on the inside of their lip. It doesn't have to be a baby food. It's just a convenience item. So what we are going to try and do for these infants, we're going back to the newborn nursery, is we're going to take them to breastfeeding school. And we're going to let them practice at the breast, and we're going to supplement them until they can get where they need to be, knowing that they should be able to be strong enough and coordinated enough by their due date. Usually earlier, but by their due date is what we want to say, right? Those babies born premature, we tell the families, don't expect them to meet all of their developmental milestones until they're 2, right? That's where we want to see 2, right? So we're not going to tell this parent, oh, in a week you'll be good. We're going to give them some ideas on how to manage that with supporting them to get a good latch, practicing, giving all those exposures, and then expressing milk in some way, shape, or form to be able to provide. And then efficient feeding strategies. I'm going to go through my favorite one in a second. And then supplementation to make sure they're maintaining their weight. These are the babies you're going to see frequently. This is pace bottle feeding. Anybody know how to do pace bottle feeding? You don't count. You do count, but not for that question. Has anybody seen it? So this is the feeding teams that they do this all the time in the NICU, right? As they're trying to get a baby to feed. And the idea behind the pace bottle feeding is you're trying the best that you can to mimic what we want at the breast. The baby is sitting up, right? Facing the front, chin up. The bottle goes straight into their mouth with a wide latch, as deep as you can get them onto that bottle. And you can see that the milk level is just filling the nipple, but they're not underneath of it. It's not gravity dropping, because if they're underneath and they're feeding with gravity, they're more likely to get faster flows, bigger boluses. And in infants that are struggling with that oral phase of feeding, they can't handle it. It also will help them to coordinate and being able to recognize that the breast is slower than that rapid usually. That flow of milk from the breast is a little bit slower, so they're not anticipating that fast feed. It's not normal for them to eat in 7 minutes flat, right? You don't want to eat in 7 minutes flat, you're going to have a bellyache, and so do they. So slowing them down, giving them the opportunity to control how fast it comes down, breathe in between the swallows becomes really important. So, because while the spoon is great in the newborn nursery, it's not a long-term fix, right? It's hard to do, and it's not easy to do when you're traveling and out someplace. So if you've got a 3-week-old and you have to take your kid to the, I don't know, swim class, you're not going to use a spoon to feed them. This is another way to do it. We have to talk about supplementation, because moms may not have enough. We anticipate them not having enough. So we've talked long and hard about mother's own milk. The other option would be formula, and that's mostly what we go to, right, for a lot of reasons there. It's easily available, and cost-wise, it's not cheap, but it is also a whole lot less expensive than donor milk. And donor milk is the other option, and there's a bunch of things that go into that. We're going to talk a little bit about the differences there. Now, I'm going to tell you here and now, the next slide, you're going to go, oh my gosh, I use formula, right? There are times when it is our only option, and that has a place, but you want to still maximize and support moms being able to give their babies food. So we want to give as much as we can from a mother's own milk, and then offering the formula. But this is the climate we're in with formula right now. So huge publicity comments that came out through the World Health Organization and UNICEF, this was a year ago, that kind of berated the formula industry for all of their predatory marketing. And you see that everywhere. They sponsor our meetings, they bring us formula, to be able to give out, they direct market to the infants, so that, and they have this nice little thing that says breast is best, but here's an option, right? And we know very clearly that if you're not pulling it, you're offering alternatives, the milk just goes away. So in the long term, it interferes with that. Babies need to eat, they need to grow, and so if this is our option, this is our option. But they also need to know the risks that go along with it. I was looking at some information on the litigation that's come out recently, specifically related to formula use in the newborn nursery and NEC, and I was shocked at the number of lawyer sites that have now been blowing up my phone because I went looking. This is a conglomeration of all of the recent cases. And they're in various stages of the process, but this is what families are seeing. So we need to give them an alternative, right? And so many people now coming in and using the formulas from Australia and from Switzerland and France, and we don't have great information on those. Anyway, that comes to a different conversation. If we look at the difference between breast milk and formula, and I'm going to give a little shout out to one of our colleagues who donated some breast milk to me a couple years ago. And the pathologist at Tech was so excited he tried to get it published, and unfortunately they were not interested. But breast milk on the side, you're seeing all the white is fat globules. That is fat, right? And then you can see all the cellular components, and you've got all of the different phases of the white blood cells present, and that's being presented in the mouth, in the gut, and really makes a big difference. Versus formula on the side, the pathologist was interesting. He was like, look at that crap. But that's protein. That's all that is protein clumps in water. Let's talk a little bit about human donor milk, which is expensive, right? I mean, I think I was told, so King's Daughters Milk Bank has been providing human donor milk that's been pasteurized to Carilion since 2014. And I think Dr. Pierce told me it was tens of thousands of dollars a month is what we're spending. And that's just for the NICU, right? It's about $5 an ounce to get if you're going to pay cash for it. Now, I'm going to talk to you a little bit about the human milk banking process, specifically through Humana, which has over 20 sites in North America, Canada, and the US to be able to provide, milk to infants. And the priority is to preterm infants, period, and to high-risk infants like cardiac disease, so on and so forth. Thank you to my friend who just told me I'm running out of time. So the milk process, milk is collected and tested. Moms are tested. The milk is tested for bacterial samples, and the ones that are deemed acceptable then get pooled. And the reason is related to the milk itself. The mother who is postpartum by 1 month versus a mother who's postpartum by 11 months, the milk looks different. So they pool it to be able to give a consistent calorie content. It's then heated to 62 degrees Celsius for 30 minutes and then rapidly cooled. And then that sample is then externally tested to confirm that there's no bacteria in it. It's then kind of stored and then presented to the different hospitals for the NICUs, as well as, like I said, the at-risk infants. It changes the components of the milk, pure and simple. The nutritional component is not different for the most part. There are some differences in the vitamins that are presented. The fat-soluble vitamins typically stay, the water-soluble vitamins typically are destroyed. But there's not any of the immune protection that's there. I shouldn't say any. The lactoferrin is less, the cytokine is less, the IgA is less, but those all have different subsets. And so depending on which version we're talking about, you'll see less of that. The cells are gone. There's no stem cells and neutrophils that are in there. And we also lose that probiotic effect, prebiotic effect with the bacteria that is transferred through the breast milk. When we look at the content, so if I'm looking at mothers of milk of a preterm infant, the calories are significantly greater than what's averaged because, again, it's pooled, right? And the average is significantly greater than donor human milk, pasteurized donor human milk. And the protein is higher too, right? We need that for growth. That protein becomes super important. Now, let me talk to you a little bit about what the Virginia chapter is. I have loved this organization. It has been such a great group of people and working in all different aspects. And so one of the things that we're charged with, one of which is education, the other one of the other ones is advocacy. And that advocacy comes in things like this, teaching different aspects, as well as advocacy at the legislative level. So one of the legislative things that we are working toward and supporting, we are not bringing this to the legislation, but there's I think she is a delegate that will be sponsoring a bill for coverage for donor human milk in the state of Virginia. In the US, there are, I think we're at like 19 states where the human donor milk is covered by the insurance companies and Medicaid. Would that make a huge impact in our bottom line, right? For the hospitals as well as for families. And ideally, it will still support the very low birth weight infants, the infants under certain gestational ages, and I put that there because it's not designated specifically in the bill, and it varies from state to state, and what they choose to put there. And then the high-risk infants, like we talked about, that we hope to be able to make happen in Virginia next year. There's 2 of us that serve the state as the breastfeeding co-champions, and I put our information up here if you have questions or concerns. Please let us know. If there's issues that you're seeing in your practice and you want some guidance on, we'd be happy to push that agenda on a different level too. We have 2 minutes. Anything that you would like for me to clarify? Anything on the line you want me to go through? Yeah.
I have a question.
There's someone right here.
Yeah, go ahead.
Does breast milk go through the same screening as the blood products, like in terms of hepatitis or HIV?
Yes. So, yes, they are testing for anything communicable. Absolutely. And CMV, all of that's in there. Yeah. Yeah.
When we talk about the differences in mortality or illness between babies who are exclusively breastfed and babies who are not, how do we control for factors like increased maternal ability to provide attention, increased maternal resources? Because it seems like people who are better off would have more time to breastfeed their infants also.
That is true in some areas. So that one's a tough one to tease out because it is multifactorial for sure, right? I've had lawyers and dentists who went back to work at 10 days postpartum and they were not able to breastfeed, versus I've had single moms who were 17 who have exclusively nursed their babies for 18 months. So it's so individualized. I think your question is a great one. And to be honest, we don't have a great way to separate that out until we have more data long-term. And some of that immunization study looks at that. It's not reported in a way that I could present to you today. You said someone else had a question.
Dr. Hart had a question.
Dr. Hart.
So he's asking about donor milk.
Yeah.
Given the variability, is there any efforts to standardize human milk donor banks to improve the quality of human milk donor milk?
I'm not sure I understand the question. There are efforts in the donor realm, I mean in the Himbana realm, to be able to prioritize different things. For example, some of the Himbana sites are able to pool just preterm milk.
Hey, Cameron, can you hear me this?
Volume. And then we can hear you.
Cameron, can you hear me? This is Michael Hart. Can you hear me okay?
Hi, Dr. Hart.
Hey there. I sent out an article a week or two ago that looked at a worldwide variation in donor breast milk banks from Poland to Chile to Kenya. There's a lot of variability, and not to mention there's variability in the stage of lactation, as you mentioned, and whether they're preterm or not. One of the things that concern me, though, is universally worldwide, the donor milk DHA levels are extremely low. And I've been worried that, to me, the problem could simply be solved if there was counseling in all women who are donating their breast milk to maintain their prenatal vitamins and their DHA supplements during their donation. I have a hunch that a lot of women who are donating slack off their prenatals and their DHA supplements as they go through the process of feeding their own child to donating their milk. And I wonder if education of the donors is one way we could solve this.
That's a really good point. And you're absolutely right. Where nutrition, maternal nutrition plays such a role in what's available. For the preterm infant, we're still doing all of the vitamin supplementation, regardless of whether they're getting the formula or the donor milk / mother's own milk. And that has to do with some of that variability. The preterm milk, and I'm kind of narrowing that down a little bit, the preterm milk typically is because of fetal demise. And so there's a lot of those moms it's a part of their grieving process. And so that's going to be pretty variable in how many of them are maintaining their nutritional status and their prenatal vitamins depending on their coping strategies. You're absolutely right. Being able to have good nutrition for all people would be ideal. But most of the moms that I've had who've donated milk are moms who have an oversupply and are not continuing to pump and donate after their child has stopped nursing. So I am always counseling them. If you're nursing, you should be using extra vitamin D and your prenatal vitamins consistently. And I would encourage you to make sure that you're talking to the moms about that too, as well as just good food. There's not a ton of good data on there on limiting certain things in mom's diet. So used to be, you can't have beans and you can't have the cruciferous vegetables and you can't have onions, and that has nothing to do with anything. So
That sounds great. One last quick question. Have we made any inroads to the cultural divide, the racial divide, because our African-American population's prevalence to breastfeeding was so low, and I learned that this was more of a cultural sensitivity issue dating back for hundreds of years. Have we made any inroads as far as prevalence of African-American nursing rates in Virginia or in the United States?
I thank you so much for bringing that up. That is a very well-known issue, and the benefits to mom, which I did not go through here at all, the benefits to mom and benefits to babies that are lactating and or getting mom's own milk in the African-American population is significantly greater than it is in specifically related to like breast cancer rates. We see a huge difference in that from moms who are nursing. There are efforts ongoing, and there's a lot, every year there's a conversation from the perspective of a societal impact and how we can make a difference. This goes back to a little bit of the cultural impact from slavery and the kind of impact that was there in terms of separating infants, mandating that the women were nursing the master's child instead. And so there's a lot of trauma that goes into that, so many layers to this. And so the efforts are really focusing on having small groups in different communities that are led by community members in areas of, and there's great programs out there. There's one called Rose, and it is essentially women in the communities going to churches and supporting young mothers to be able to support their infants and making a big impact. That is growing exponentially. The current ABM president has kind of really facilitated that process, and so it's in the discussions a lot and what we can do.
Wonderful. Thank you.
Thank you.